start the first session in this very prestigious program. And this first session, we have like 8 presentations. The first one is Professor Eric Weiner, and his talk will be on the art of selection of anti-HER2 therapy in neoadjuvant and adjuvant settings of breast cancer. Professor Eric Weiner is the chief of the Division of Women's Cancers, director of the Breast Oncology Center, and Thompson Senior Investigator in Breast Cancer Research at Dana-Farber Cancer Institute. He's professor, Department of Medicine, Harvard Medical School, physician, Brigham and Women's Hospital, and ASCO Board Directors member in USA. Professor Eric Weiner, please.
Thank you very much for that introduction, and thank you for having me here. I'm honored to be here. I was actually quite struck by that film that you showed a little earlier. So my job over the next 25 minutes is to talk about treatment of HER2-positive early-stage breast cancer, in contrast to what Dr. Tripathi will talk about later, focusing on metastatic breast cancer. So I show first the natural history of HER2-positive breast cancer without trastuzumab. And these data come from a study done not terribly long ago, a study conducted in the United States, CALGB 9344, and looked at patients who received either AC chemotherapy or AC plus paclitaxel. This focuses only on the patients who had either estrogen receptor positive or negative, but all had HER2 positive breast cancer. And what you can see is that even with paclitaxel in this group of patients with node-positive breast cancer, that somewhere in the range of 25 to 30% of these patients are developing, are dying of their HER2-positive breast cancer by 10 years. There are, of course, many opportunities to take advantage of what we know preclinically about the HER2 pathway. And much of this work has gone on over the course of the past 2 decades. I think some might argue, and I would argue, that we probably know more about the underlying behavior of HER2-positive breast cancer than any other subtype of the disease. But even there are still many, many unanswered questions. We know that HER2 is a member of the epidermal growth factor family of receptors that includes HER1, HER2, HER3, and HER4. And armed with this understanding and with some understanding of the underlying signal transduction that occurs as a result of activation of HER2, new therapies have been developed. That said, there are still many unanswered questions about to what extent Herceptin or trastuzumab works not through signal transduction, but in fact works as a result of immune mechanisms. The initial studies with trastuzumab that were now presented 10 years ago at ASCO are shown here on this slide. 2 of these trials, the NSABP trial and the North Central trial, the 2 trials shown on the upper left-hand portion of the study, were combined together because they essentially asked the same question. And that question was whether if you added trastuzumab to AC followed by paclitaxel, the outcome was improved. And that is often referred to as the joint analysis. And these are the updated data from that joint analysis published in the JCO just this past year. And I think it's quite striking to look at these long-term results. On the left-hand portion of the slide is overall survival. On the right-hand portion of the slide is disease-free survival. And what you can see is that with truly long-term follow-up, now through approximately 10 years, that there's an approximately a 10% improvement in overall survival and a similar improvement in disease-free survival. What I am not showing you is a slide from this same presentation that was given approximately a year ago at San Antonio, which demonstrated that, in fact, women who received AC followed by paclitaxel and trastuzumab had only about a 12% risk of distant recurrence as a first event. Now, of course, this was not the only strategy that was looked at, and in the United States, in fact, AC followed by paclitaxel and trastuzumab is not the most common regimen given. The most common regimen comes from this study, BCIRG 006, and in this trial, women with HER2-positive breast cancer were randomized to receive either AC followed by docetaxel, AC followed by docetaxel with trastuzumab, or the non-anthracycline containing regimen TCH, docetaxel, carboplatin, and trastuzumab. These are the results as published in the New England Journal now several years ago. And what they demonstrated was that either trastuzumab containing arm performed better than the non-trastuzumab containing arm, but there was a slight numeric advantage for the anthracycline containing regimen versus the non-anthracycline containing regimen. The differences were not statistically significant, but this is also not a study that was designed to test the equivalence of a non-anthracycline and an anthracycline containing regimen. I think it has perplexed some of us that in the United States, the anthracyclines have been so easily dropped from the treatment of many patients with HER2-positive breast cancer. There's been a great deal made of the cardiac toxicity of anthracyclines, and there has been a sense, although probably a sense that is a bit misguided given the data that I just showed you, that TCH is every bit as good. And on this slide, if you look in the blue column, I totaled up in this study the number of disease-free survival events plus the number of congestive heart failure events. And what you can see is that the group of patients who had the fewest number of events, or the arm of the study where there were the fewest events, were in fact patients who received AC followed by TH. Now, does this mean that we have to include anthracyclines in the treatment regimen in all patients and forevermore? And my answer to that is no, and no, nothing would make me happier than to be able to say goodbye to drugs like adriamycin and epirubicin forever. But I think at the moment, given the data that we have, that if one is faced with a patient who is at moderate to high risk of recurrence and who is at low risk of cardiac toxicity because she doesn't have a history of hypertension, she doesn't have other cardiac risk factors, and she's young, then in that situation, I do tend to think that an anthracycline-containing regimen is the best choice. Now, in truth, these are all 10-year-old data. And in just a few minutes, we'll talk about some of the newer regimens, although much of what I've shown you is still what, in fact, we are doing in clinical practice. The investigators from the HERA study asked the question whether 2 years of trastuzumab was better than 1 year of trastuzumab, and as you can see here, whether a patient had hormone receptor negative or hormone receptor positive disease, the duration of trastuzumab, 1 versus 2 years, seemed to make no significant difference. And similarly, another study looking at duration, 12 months versus 6 months, what was similar is that they asked a question of duration, but what was not similar was that, in fact, in this study, the so-called FARA study that was conducted in France, the suggestion was, in fact, that a year was better than 6 months. Now, is this true across all patients? Are there patients who might do well with shorter courses of therapy? And I think that that's a very important question, both from the standpoint of patient convenience and cost, and as we consider applying these treatments around the world, being able to minimize the therapy that we give and at the same time achieving a therapeutic benefit is, of course, critical. But I think, unfortunately, at the moment, what we're left with is the fact that a year of trastuzumab is, in fact, the standard duration, and we can't identify any patient population where, if we're going to give trastuzumab, a shorter duration is equivalent. Now, I mentioned just a few minutes ago that we'd talk about some newer data, and much of this comes from the recently reported ALTO study. I think, as many of you know, ALTO was a fairly complex study that ultimately compared trastuzumab, lapatinib, trastuzumab and lapatinib, or trastuzumab followed by lapatinib. Early in the course of the study, the lapatinib-only arm was dropped because there was this suggestion that it was not performing as well. Now, many of us expected that this study could be positive, and much of that was based on results from neoadjuvant trials, which strongly suggested that the combination of trastuzumab and lapatinib was more effective than trastuzumab alone. And in fact, as judged by pathologic complete response, the pathologic complete response rate with a combination of these two anti-HER2 drugs was clearly superior to either of them alone. I think much to the disappointment of many, these were the results. And there was not a statistically significant improvement for the addition of lapatinib to trastuzumab, whether that was giving it concurrently with trastuzumab or sequentially with trastuzumab. And in spite of the fact that these investigators looked at a variety of different subgroups, they looked at patients with estrogen receptor negative versus estrogen receptor positive disease. They looked at the administration of anti-HER2 therapy concurrently and sequentially with chemotherapy. But in each and every one of the subgroups, while there were small differences, there was no group where there was a clear and unquestioned advantage for the combination of trastuzumab and lapatinib. And I should add that this combination was associated with substantially more toxicity, particularly GI toxicity. So in 2015, what role does lapatinib play in the treatment of early-stage breast cancer? Well, I would actually say that it simply does not have a role in the management of early-stage HER2-positive breast cancer. Trastuzumab remains the standard. Lapatinib should not be substituted. Lapatinib should not be added. And whether or not other small molecule tyrosine kinase inhibitors, such as neratinib, will ultimately play a role, I think, is an unanswered question. What about pertuzumab? Of course, there has been a great deal of focus on pertuzumab over the course of the past several years. And there has been a trial that has looked at adjuvant pertuzumab, the so-called Affinity trial, and in this trial, patients were randomized to chemotherapy plus trastuzumab plus a placebo versus chemotherapy plus trastuzumab and pertuzumab, all of the antibody therapy being given for 1 year. This study is fully accrued. It completed accrual now over a year ago, and we are waiting for a result. I think there are many who believe that this study will in fact be a positive study, and much of that is a result of the very dramatic findings that were reported this past year from the Cleopatra trial, the trial that established the role of pertuzumab in the metastatic setting. And in that trial, there was a 16-month survival advantage associated with pertuzumab treatment given in the first line. And with this in mind, I think many believe that the Affinity trial will be positive and that within the next several years, pertuzumab plus trastuzumab may become the standard. It is not at the present time. Just one last study to mention in the adjuvant setting before moving on and talking about preoperative therapy, and that is the so-called Caitlin study. This study takes advantage of another anti-HER2 agent, the agent being TDM1 or Kadcyla. And in this study, patients are randomized to AC followed by paclitaxel, trastuzumab, and pertuzumab. Now, I just said that that's not a standard regimen. It was included in this study with the assumption that it might be a standard regimen within the next year or 2 or 3. And patients are randomized to receive either AC followed by THP or AC, and there's a mistake here. There should be an AC in that lower arm, AC followed by TDM1P. Now, in truth, this is not really the study with TDM1 that I would like to see done, because in fact it still includes an anthracycline. It is still essentially toxic chemotherapy. And I think one of the real advantages that many of us see in terms of TDM1 is that it may ultimately be able to replace much of the chemotherapy we give. Now, I said we'd talk about preoperative therapy, but one detour first, and that is to talk for just a minute or two about patients who have small HER2-positive tumors in the setting of lymph node negative disease. When the initial studies with trastuzumab came out, everyone recognized that they had largely been done in patients with either node-positive disease, as was the case with most of the U.S. studies, or in patients with node-positive and high-risk node-negative disease. And how one should approach a patient with, for example, stage 1 HER2-positive breast cancer was somewhat unclear, and that was particularly the case if we started talking about patients who had tumors that were 6 millimeters or 8 millimeters or 9 millimeters. But for that matter, similar questions arose for patients who had T1C tumors as well, many of whom were not included in the earlier trials. This report came from MD Anderson in 2009 and suggested that among patients who had HER2-positive breast cancer and had tumors less than a centimeter, that indeed the 5-year relapse-free survival was much lower than one would optimally like to see, with 23% of patients having a disease event in the absence of any treatment, and the 5-year freedom from distant relapse was approximately 85%. Other investigators presented somewhat more favorable results, but I think that the bottom line is that if we're talking about patients with small node-negative tumors, that these risks of recurrence that I've listed on this slide are approximately what one could expect. For patients with T1A tumors, a risk of recurrence at 5 years in the range of 2 to 10%, a little higher for T1B tumors, and higher than that for T1C tumors. And with the exception of the patients who have T1A tumors, I think that these are risks of recurrence that are high enough that in many settings there's an interest in administering some type of therapy to reduce the risk of recurrence. The problem from our standpoint was that we did not want to give as toxic a regimen as something like ACTH or TCH. And with that in mind, we actually started a trial in 2007 that looked at the administration of 12 weeks of paclitaxel with trastuzumab, followed by the completion of a year of trastuzumab. This was a non-randomized trial. We would have loved to do a randomized trial of either trastuzumab, yes or no, or a trial that looked at different trastuzumab-containing regimens, but none of these were felt to be practical. And with that in mind, we decided to at least answer a question that we felt we could answer. So we included just over 400 patients in this study. This was a study that was done at about 12 centers around the United States. As you can see, the age range was quite mixed. Half of the patients had tumors less than a centimeter. Half of the patients actually had tumors greater than a centimeter, with about 10% having T2 tumors. About two-thirds of the patients had ER-positive disease. A third had ER-negative. All, again, had HER2-positive breast cancer. And as reported actually last week, I think, in the New England Journal by my colleague Sarah Tallaney, these are the 3-year disease-free survival data. with a 98.7 3-year disease-free survival. And if, in fact, one actually looks at the events that occurred, there were only 2 events that were distant recurrences. Several of the events were indeed HER2-negative contralateral cancers, although they were still events that we included in the analysis. And in our mind, what this says is that if, in fact, you are facing a patient with stage 1 HER2-positive breast cancer, and you and the patient have decided that you're going to use a chemotherapy and trastuzumab regimen, the 12-week paclitaxel and trastuzumab regimen, followed by trastuzumab for the completion of a year, is a very reasonable approach. We are not for a minute suggesting that this is required for all patients, that, for example, you should be treating patients who have 3-millimeter cancers with this regimen. We recognize that some of the more standard regimens like ACTH or TCH, all of which are more toxic, might be still considered for some patients with particularly high-risk features. For example, the 32-year-old with an ER-negative 1.9 centimeter high-grade HER2-positive cancer with diffuse lymphovascular invasion. That may be someone you're not comfortable using a lesser regimen. But for most patients, this would seem to be a very reasonable standard. We will, of course, follow this cohort over time to be sure that there isn't any substantial diminution of effect over time. And finally, in all biologic regimen, a regimen such as pertuzumab and trastuzumab or trastuzumab and some other biologic agent might have even lower toxicity and could be tested, but the routine addition of any additional biologic therapy to the TH backbone would seem unnecessary in this situation. And our ongoing trial is actually looking at T-DM1 as a single agent and comparing that to the TH regimen, not thinking that we can achieve a better result in terms of fewer recurrences, but that we can achieve a result with less toxicity. So in the last few minutes, let's talk about neoadjuvant therapy. I just want to remind everyone that there are a limited number of reasons why we administer neoadjuvant therapy. We do so to facilitate surgery in patients with locally advanced disease, to downstage operable disease and allow a patient who might presently need a mastectomy to undergo breast conservation by shrinking the tumor, perhaps to decrease the extent of axillary surgery, and finally, as a participant in clinical trials. Outside of a clinical trial, when you're giving neoadjuvant therapy in patients with HER2-positive breast cancer, in my view, any standard adjuvant regimen is appropriate to be used in the neoadjuvant setting. There's no disadvantage outside of a trial in giving neoadjuvant therapy, but keep in mind that the real advantage is being able to do somewhat less in the way of surgery. And if you already have someone who can have conservative surgery, or you have somebody who is determined to have a mastectomy no matter what is achieved, then there may be little reason to pursue neoadjuvant therapy. We know from work done by Pat Kodazar at the U.S. FDA that, in fact, when you give neoadjuvant therapy, the rate of pathologic complete response varies dramatically by tumor subtype, and that among those patients who have HER2-positive breast cancer, shown in the middle in the orange and purple bars, that the pathologic complete response rate is higher in patients with hormone receptor negative versus hormone receptor positive HER2-positive disease, and seems to be higher, and studies have demonstrated this with the addition of trastuzumab. We know that from the NOAA trial, now conducted approximately a decade ago, that the addition of trastuzumab to chemotherapy not only increased the pathologic complete response rate, but was associated with an improvement in long-term outcomes. That said, the degree to which changes in pathologic complete response correlate with long-term outcome remains unclear in most settings. Many patients with residual disease still do well, even with residual disease, and we do not know that an improvement in PCR will across the board result in a better disease-free and overall survival. And for this reason, when we look at neoadjuvant approaches, we should be cautious about adopting new neoadjuvant approaches without long-term data, and we should not use neoadjuvant results, at least yet, to determine adjuvant regimens. We learned this lesson the hard way from the studies that looked at lapatinib in the neoadjuvant setting. I referred to this earlier. This is the NEO-ALTO trial that showed a doubling of the pathologic complete response, and yet the ALTO trial itself was a negative trial. We had a relatively similar result in a CLGB study with a essentially identical design, where the combination regimen achieved the highest rate of pathologic complete response. I show you this simply to emphasize that not only does hormone receptor status affect the pathologic complete response rate, but intrinsic subtype affects the pathologic complete response rate. And this may serve as a clue in the future. I'm almost done. I think I'm done. Oh, no, here we go. This may serve as a clue in the future as to how to design trials within subgroups of patients with HER2-positive disease. And finally, in terms of pertuzumab, similar data to what's been seen with lapatinib have been produced with pertuzumab, where the combination of trastuzumab and pertuzumab and chemotherapy led to the highest pathologic complete response rate in NeoSphere. There are also data from this study that suggested that the two antibodies alone in a subset of patients were highly effective, and at least gives some of us hope that, in fact, for some subpopulation, that it may be possible to use antibody therapy alone. As you are probably aware, in the U.S., the FDA approved pertuzumab in the preoperative setting in patients with tumors greater than 2 centimeters with negative or positive lymph nodes. They approved a variety of regimens. In the U.S., pertuzumab-containing regimens have become relatively standard in the neoadjuvant setting. I realize this is not the case around the world, and I must tell you that I am not completely in agreement with this approach. And while we do give preoperative pertuzumab because it has been approved, I think that approval was somewhat premature. And again, outside of a clinical trial, I would say that a trastuzumab-containing regimen remains the standard without additional anti-HER2 therapy. And finally, just two additional studies that I want to mention. One is a trial that has now been published that was done in the Translational Breast Cancer Research Consortium and looked at the use of trastuzumab, lapatinib, and endocrine therapy, largely in patients with ER-positive, HER2-positive disease. And I show you this simply to emphasize that giving the endocrine therapy in conjunction with HER2-positive anti-HER2 therapy in this study appeared to be a very effective approach. This is now being tested in a larger study, but there are those who believe that the combination of endocrine therapy and anti-HER2 therapy may one day allow us to eliminate chemotherapy from this patient population. And finally, a study we have going on at our own institution, which is TDM1 and pertuzumab as the preoperative regimen in patients with stage